speak yesterday and this morning for the IBD and the pathology finding. This time, she will speak how can radio frequency help in fecal continuum. Please, Dr. Mariana Bellhorn.
Thank you. Thank you so much for that again. This is our last time. So, kind of to complement what Steve was talking about radio frequency and fecal incontinence, I think it's always easier when we know why things happen, and that's what I would like to share with you, because we created an animal model and we were able to find out partially why the changes take place. So I think I'm going to go through this really quickly because Steve already has explained all of the different studies that have shown the efficacy of radio frequency in fecal incontinence. I mean, I've always thought that this gentleman had to be Japanese, but it seems that he lives in Mexico, so he speaks Spanish. Figure that one out. But in any case, he was the first one to do the studies, but after that there was many other studies that have proven the benefit of using radio frequency for fecal incontinence. And then, as Steve mentioned, we do have a double-blind sham control study for the efficacy of radio frequency in reflux, gastroesophageal reflux. And there's more than one randomized control study for the upper GI tract. So what we wanted to see in this animal model is we wanted to figure out where were the histopathological changes that we see after the animals receive the radio frequency treatment. This is a study that is in breast colorectal disease. Thankfully, it will probably come in the next 2 months if you want to read it. So this is the way the animal model went. I mean, it starts with anal dilatation, and on one side, on the right side, the injury was a mechanical injury of both the internal and the external anal sphincter. And on the left side, it was injury to the pudendal nerve using alcohol. Then palpation and manometry was done at 20 minutes after the injury, and then at 4 weeks after the procedure, both basal and squeeze anal pressure. So this is how the animals were divided. There were 16 females. So 8 of them had the procedure, the damage, and then received radio frequency. Then 4 of them had the induction of fecal incontinence, but they did not receive any kind of treatment. And then we had 4 controls in which nothing was done to the animals. And the animals were sacrificed at 3 months. The way that radio frequency was given to the animals is exactly the same that Steve explained that is done for humans. So this is the part that from a pathology point of view, had to make a lot of sense to me. That is the way that the section is going to be taken from each of the animals. So you have here, this is going to the anus, you have the skin, squamous epithelium, then you have the rectal mucosa, and you see the skeletal muscle of the external sphincter. So there were several different criteria or parameters that we wanted to study that were obviously different in the internal anal sphincter and the external. For the internal anal sphincter, we wanted to see the ratio between the smooth muscle and the connective tissue. We wanted to see also the ratio between the different types of collagen, particularly collagen 1 and 3. We did this by immunohistochemical stains. We wanted to see if there was some kind of differentiation from fibroblast to myofibroblast and final differentiation into smooth muscle cells. And we use smooth muscle actin to do that. And then the other thing that we were interested in was to see what were the changes that radio frequency induced in the interstitial cells of the bowel. And and we use a particular immunostain that is CD117. The way we did all this was using image analysis. I did the study without knowing which animal I was looking at, so it was a blind study. For the external anal sphincter, we characterized the amount of type 1 and type 2 skeletal muscle fibers using a particular histochemical stain that is used for all kinds of skeletal muscle studies. And again, this was done in a semi-quantitative way by image analysis. So let me show you what we found in the internal anal sphincter. First thing that we saw is that after the animals with the fecal incontinence received radio frequency, the height measured in microns was very close to the control compared to the animals that had the fecal incontinence and did not receive any kind of treatment. The width, we saw similar changes. You can see the animals that received the treatment had a width closer to the control compared to the ones that did not have any treatment at all. One important thing that we wanted to see is if there was really an increase in connective tissue, because some people have suggested that the way that radiofrequency works is through the induction of fibrosis, which wouldn't be really what we want to see. And actually, we were able to show that that is not the case, because when you look at the width of the septum in microns, the animals that received radiofrequency had a width closer to the control compared to the ones that did not receive the radiofrequency. So, in other words, there's a reduction in the connective tissue in the collagen when the radiofrequency is given to the animals. We also saw, as a consequence of all this, that the percentage of smooth muscle in the internal sphincter was increased in the animals that received the treatment much closer to the control compared to the ones that didn't, and the opposite with the percentage of connective tissue. Now, so we did, as I was telling you, we used a trichrome stain to evaluate the fibrosis, and the animals that did not receive any treatment had an increased deposition of collagen. If you remember, the collagen with this stain is blue and the muscle is red. So there was more collagen, more connective tissue in the animals that did not receive any treatment. Same situation, we did a smooth muscle actin that is just an intermediate filament that characterizes smooth muscle cells, and we can see the brown staining is the staining of the muscle. And you can see that there's less muscle in the animals that did not receive any treatment compared to the ones that did. When we were doing this, I was thinking, but where are these smooth muscle cells coming from? Because if you remember, smooth muscle cells are very differentiated type of cells. They don't multiply, kind of like the neurons in the brain, so it had to come from somewhere. So the idea is that fibroblasts have the ability to differentiate first to myofibroblasts and then to smooth muscle fibers. And to prove this, we did again the smooth muscle actin, and what we saw is that cells that look like fibroblasts under the microscope, so they had the features of a fibroblast, were actually expressing actins. That's telling us that they're differentiating towards myofibroblasts, and likely those are the ones that give us the new smooth muscle cells. Another important thing that we wanted to concentrate on was the interstitial cells of Cajal. I mean, I'm sure you remember, these are important cells in the rectoanal reflex. And if for example, if you do pediatric medicine, you'll see many of patients that have these conditions in which there's a decrease in the interstitial cells of Cajals, typically Hirschsprung's disease. So clearly, interstitial cells of Cajals have a very important function in continence. So we were figuring that then in contrast to Hirschsprung's disease, it would be possible that having too many interstitial cells of Cajal could be related to a fecal incontinence. So what we did, and this had been proven before, this lady is one of the ladies that is part of the study. She is in Poland with Professor Herman. So what we did see, and we count this by image analysis, is that in the animals that did not receive any radiofrequency, the interstitial cells of Cajal were significantly higher in number compared to the ones in which the animals did receive radiofrequency. Now, moving to the external sphincter, as you remember, there's basically two types of skeletal muscle fibers everywhere in the body. The type 1, we call them red because with that histochemical stain, they stain red. These are the fibers that contract slowly, but also they remain contracted longer, so they are resistant. They have this aerobic type of metabolism. And then we have the type 2s that we call white because they don't stain well with that histochemical stain. These have the ability to contract faster, but also they get tired faster. So we need a ratio between these two. I mean, we don't want to have all of them type 2 because then the fiber gets tired very quickly. So we wanted to see what happened after the application of the radiofrequency. And as you can see, after radiofrequency, the number of fibers type 1 in the animals that received radiofrequency was much closer to the control compared to the animals that did not receive any treatment. Instead, for the types 2, both A and B, we saw that the number of fibers, again, was closer to the control in the animals that received radiofrequency compared to the ones that didn't. So radiofrequency acts not only in the internal sphincter, but also in the external one. So in conclusion, in the internal anal sphincter, we saw that we had an increase in smooth muscle bundle height and width. There was an increase in the ratio of smooth muscle and connective tissue. I didn't show you the data, but we also saw an increase in the ratio of collagen 1 and collagen 3. We saw a reduction in the number of interstitial cells of Cajal, and we saw that progression from fibroblasts to myofibroblasts to smooth muscle cells, likely explaining why we have regeneration of the fibers. In the external sphincter, we saw an increase in the number of type 1 fibers as well as the diameter. So I hope we can understand this a little better after the experiment we did. Thank you so much.
Thank you, Dr. Mariana. The next speaker is Dr. Chen Hongzhang. I just give a short introduction to Dr. Chen Hongzhang. He is graduate from China Medical College and have full training residency in Changhua Christian Hospital. Now he is the chief colorectal surgery department in Changhua Christian Hospital, Taiwan. And this time he will give us the topic for this fall preparation routinely needed for colorectal surgery. Dr. Chen, please.
Thank you. Mr. Moderator, thanks for your nice introduction, and thanks the society for giving me the chance to present this topic. But before I start my speech, I have one thing to announce to our members of the society. 各位会员，等一下那个大会会改到那个4楼，所以他中午的大会，请麻烦各位到4楼参加。Okay. Again, before I start my speech, I want to ask our audience, how many of you do the preparation before the elective surgery? If you do, please raise your hand. Personally, I do, but only for the cycle. Quasar bulb preparation is necessary, which we take for granted for a long time. Here is the evolution of the bulb preparation. Actually, before 70s, bulb preparation has been taken for a long time due to the high rates of wound infection after abdominal surgery. So, the bulb preparation, so the surgeons use laxative and special diet to evacuate the GI tract before the surgery. Until 1972, an early challenge came out to the dogma of the bulb preparation. But until 1994, the first randomized controlled trial showing no benefits with mechanical bulb preparation. In 1971, preoperative preparation of the colon demonstrated decrease in mobility and mortality. So it was assumed that the benefit would come from significantly lowering non-selective bacterial counts. In 70s, the whole procedure is very complicated and very time-consuming, even sometimes up to 10 to 14 days with lesion or stenosis. Excuse me. And the process may be very exhausting for elderly patients, and sometimes it may lead to hypovolemia. So, until 1972, an early challenge came to the dogma of mechanical bulb preparation. Asepsis in large bowel surgery, it shows mechanical bulb cleaning loads the bowel and is unnecessary. Another experiment done in 87, mechanical bulb preparation for colonical resection and anastomosis. In this paper, Irving demonstrated a retrospective and controlled study. It shows no anastomotic leakage and very low wound infection, only 8%. But it's always hard to challenge the old tradition. So, for those in breast bulb preparation, they respond this paper as a paper disrespectful of the old tradition in surgery. But does it sound reasonable? Does it make sense? Because through this procedure, you decrease volume of intra-liver content and fecal load. So it decreases the bacterial count and may avoid the major spillage. Then you can reach the goal of improved healing of anastomosis, decrease infectious complication, improve patient outcomes. If you do the bulb preparation and get a good result, it can give the surgeons advantage of easier manipulation of the bulb. But can you really decrease the anastomotic leakage or infection? But it do bring some side effects, such as hypovolemia, electrolyte disturbance, diarrhea, and sometimes chronic explosion. Even though there is more and more publication demonstrating no benefits of bulb preparation, but let's see how the real world functions. In 1990, a survey conducted in Minnesota, 352 board-certified colon and rectal surgeons surveyed. 100% routinely used mechanical bulb preparation. PEG solution used more than 50%. After 7 years, the same survey conducted, but the results almost the same. Still 100% routinely used mechanical bulb preparation, and the same PEG solution used mostly commonly, rising up to 70%. In 2003, in ASCRS annual meeting as I remember in New Orleans, I attended the meeting. Trends in preparation for colorectal surgery done by Dr. Watson. 515 ASCRS members with an average 14 years experience each. The survey results indicated 99% routinely used mechanical valve preparation and 98% routinely used intravenous antibiotics and 75% routinely used oral antibiotics. In 2004, this paper shows no clear evidence exists that mechanical valve preparation reduced infectious complications. Osmotic or mortality is recognized, even though the data lacks statistical power to exclude type 2 error. However, valve preparation is justified based on ease of handling valve, safety of valve preparation, and low cost. And 3 years later, in ASCRS annual meeting, a survey conducted. The title is Cathartic Valve Preparation. The theme of the test last year, most ASCRS attendees polled admitted to using mechanical valve preparation. How about the European situation? In 2009, 131 Spanish colon and rectal surgeons surveyed. The results indicated 87% routinely use mechanical valve preparation, 60% for right colon, 90% for left colon, and 99% for rectum. And 2010, in Great Britain and Ireland, a survey conducted. The number of valve preparation actually reduced, but still very high. For left colectomy is 40%, low anterior resection 22%, APR is 72%. And the situation in our department is that we still routinely use mechanical valve preparation for left side column, but for right side column, we do not prepare the valve after 2008. And here is the result of our department. There is no significant difference between complication and mortality. Complication, including the osmotic leakage and the wound infection, there is no significant difference. So I think maybe it's just a matter of the how. To change our daily practice, we need more evidence to support, to give us more confidence to abandon our preparation. So we search the literature and we find some literature. Following this literature may give us more confidence. In the literature, in Adequate Valve Preparation Speech, 2005, it indicates mechanical valve preparation may load the valve and increase the instance of liquid contents. And because of the liquid contents may spillage out, may interfere with the result of the surgery. Spillage with valve preparation is 17% versus no valve preparation, 12%. And so more infectious complication may result from the valve preparation in an osmotic leakage or in wound infection. Here you can see, 6.2% versus 3.8% and 12.5% versus 6.87%. Here we can see there are two large meta-analysis studies. First one is from the Cochrane collaboration. They included 14 randomized trials with over 4,776 participants. The first primary outcome measure is osmotic leakage. Second outcome measures include wound infection, prophylactic antibiotics used in both treatment groups. Here you can see the primary outcome, osmotic leakage. There is no significant difference. Here, osmotic leakage, 4.2% with pulp preparation versus 3.4% without preparation. And for the second primary measure, wound infection, there is also no significant difference. 9.6% with pulp preparation versus 8.3% without preparation. So, the lack of proven benefit for pulp preparation allowed authors to suggest the abandonment of mechanical pulp preparation, except when needed to identify pathology or perform intraoperative colonoscopy. Second, here is another meta-analysis study from Annals of Surgery in 2009. It included 40 randomized clinical trials with over 4,859 participants. No pulp preparation was favored for all SSI with statistical significance. Here, 50.7% with pulp preparation versus 14.5% without preparation. Overall, the authors made the following conclusions. Higher risk of osmotic leakage is not suggested. Harmful effects of mechanical pulp preparation was not evident. Mechanical pulp preparation does not reduce infectious morbidity of colon surgery. And the suggested mechanical pulp preparation should be abandoned, at least from the patient's perspective. Quality of life and the patient preference, unwillingness to have the same procedure, dehydration and electrolyte disturbance, and bacterial translocation. If the pulp preparation is not feasible, how about enema once before surgery? Here's a study. It shows includes 1,300 patients using the post-mortem enema before flexible sigmoidoscope, and only 10.9% of the patients were assessed as having inadequate preparation. It seems this method is equal to oral preparation. So maybe it's a way to do the preparation. But this study shows it used a phosphoenema to compare PEG for pulp preparation. But the osmosis leakage is not decreasing. But oral preparation did give the surgeon a more cleaner bowel, but the consequences is requiring reoperation is worse in the enema group when comparing with the oral PG group. So, what should we do? I think for those patients with inadequate localization or possibility of intraoperative colonoscopy and defunctionalized osmosis, we should give them our preparation. For those who are accepting elective colon resections, our preparation is not necessary unless you need to open the lumen or do the intracorporeal osmosis, as the live demonstration we saw yesterday. In conclusion, there is sufficient evidence to abandon mechanical pulp preparation rare evidence demonstrates the benefits of mechanical bowel preparation. And bowel preparation has been shown to be harmful in few studies, and it will eventually become the standard for colorectal surgery. Thanks.
Thank you, Dr. Chen. The next speaker is Dr. Chai Yuan Yao. He was graduated from Kaohsiung Medical University since 2007, and now he has trained well in colorectal field in China Medical University Hospital, and now he is attending staff in China Medical Hospital, Union Hospital. Today, Dr. Chai will give us a lecture for transanal minimally invasive surgery, tips and tricks. Please, Dr. Chai.
Thank you, moderator. Dear everyone, it's Mariana here to present with the topic transanal minimally invasive surgery, also known as Thomas tips and tricks. Okay, before I start the topic, here are some questions, clinical questions that we may encounter during our daily practice. An otherwise healthy 50-year-old woman is found a 2 cm in size middle rectal polyp after her annual healthy checkup. How should she be treated? Or a 70-year-old man presented with clinical T1 and negative middle rectal adenocarcinoma. He has a history of severe COPD under regular use of inhaled glucocorticoids, AMI, also coronary during stent placement. How should he be treated? As we all know, colorectal adenomatous polyps are considered premalignant lesions with the potential to develop adenocarcinomas. Among rectal adenomas, for example, the incidence of malignant transformation ranges from 9% to 37.5%. Moreover, the size of these lesions is a risk factor associated with malignancy. The lesions are larger than 2 cm. The malignancy risk is also as high as 53%. Early detection and their removal of this polyp is the best way to prevent development of adenocarcinomas. Local excision is considered definitive for rectal pathological T1 invasive adenocarcinoma. The margins were clear and there are no pathological indicator of a poor prognosis. Traditionally, benign polyps and early stage rectal cancer located in the rectum were managed with transanal excision using a conventional anal retractors. This approach has some limitations, as exposure and visibility within rectal lumens curtail the surgeon's ability to perform high-quality oncological excisions. Furthermore, if lesions in the proximal 2/3 of a rectum cannot be approached transanally, leaving a major transabdominal resection as the only alternative to the patient.